Dear colleagues, good morning. I'm Dr. Zhang from CHIA-YI Christian Hospital of Taiwan. First of all, I would like to thank the organizing committee of Korean Oncologic-Hyperthermia Study Group to invite me to attend this symposium. And I have the opportunity to share some experience with you. Today, I will talk about immune checkpoint inhibitors and local hyperthermia. Here is my disclosure. And let me introduce our moderated electrohyperthermia treatment center. We have operated since March 2020. We have treated 98 patients and over 1,600 treatment sections. Electrohyperthermia is a self-paid treatment item in Taiwan without national health insurance coverage. The charge is similar to Korea. Here's my outline. I first present a case and discuss the implication of this case and immunological responses of electrohyperthermia. Case presentation, a 64-year-old gentleman, a retired engineer with smoking history of 2 packs per day for 35 years. Had chronic cough for 2 years. He was treated as a chronic bronchitis. Later on, the patient developed tachycardia with heart rate more than 100 per minute for 1 week. He came to the hospital and further investigation by CT scan showed 8.1 times 7.4 cm left lower lobe lung tumor with central necrosis, pericardial invasion, proceeding mediastinal and left supraclavicular lymphoadenopathy. Staging workup concluded a clinical T4, N3, and M1B stage. He also was suspected to have 6 rib metastases. CT guide biopsy revealed squamous cell carcinoma with adenosquamous component, moderately differentiated. Molecular testing showed no EGFR mutation, ALK was negative, ROS1 was negative, and PD-L1 expression was 52%. The tumor was considered non-operable. After evaluation and discussion, the patient received immunotherapy with pembrolizumab. There is Keytruda 200 mg every 3 weeks and moderated electrohyperthermia every week. No chemotherapy or radiotherapy was prescribed. Electrohyperthermia was given by Oncofirm 2000 plus and 30 cm diameter electrode. Tumor heating was generated by a 13.56 megahertz radio frequency, and the treatment was 60 minutes for every section. Thermal dose for each electrohyperthermia treatment was 556 kilojoule in average. Here is the treatment results. After 1 cycle of pembrolizumab and 2 sections of electrohyperthermia, the patient's chronic cough subsided, and his heart rate normalized about 70 to 80 beats per minute. After 6 cycles of pembrolizumab and 18 sections of electrohyperthermia, follow-up CT scan showed dramatic response. The tumor strength from 8.1 times 7.4 cm to 2.4 times 1.4 cm. The patient was asymptomatic after 9 months of initial treatment. Because of good response, the primary tumor became operable. So surgical operation was done, and a residual tumor was seen in the surgical specimen. He is now undergoing chemotherapy. Here, from a big tumor strength to a small one, have a good PR, and proceeding disappear. Discussion. The tumor microenvironment influences cancer development. The tumor environment is the environment around the tumor, including the surrounding blood vessels, immune cells, fibroblasts, and signaling molecule in the extracellular matrix. The tumor and the surrounding microenvironment are closely related and interact constantly. Tumor can influence the microenvironment by releasing extracellular signal, promoting tumor angiogenesis, and induce peripheral immune tolerance, while the immune cells in the microenvironment can affect the growth and evolution of cancerous cells. This slide illustrates the interaction of the extracellular matrix and the cancerous cells. In the microenvironment, there are many cells such as cancer-associated fibroblasts, macrophage, B regulatory cells, T cells, natural killing cells, dendritic cell, T regulatory cells, etc. They interact with the tumor cell through different protein, enzymes, and cytokines. I think everybody is familiar with this cancer immunity cycle. In short, a treatment like hypothermia radiation, chemo target treatment, and checkpoint inhibitors can destroy the tumor cells and releasing the tumor antigens. The strong antigen-presenting cell, such as DC cells, can pick up the antigen and migrate to the lymph node for priming and activation, and stimulate the immune system, causing the trafficking of T cell into the tumor and infiltration of the lymphocytes into the tumor. After that, then the T cells recognize the cancer cells. If there is no checkpoint inhibition, the T cells can initiate cytotoxicity and destroy the cancer cells, and the cycles repeats. Therefore, to have a successful immune response, there must enough quantity and quality of lymphocytes. The lymphocytes are able to recognize the cancer cells, infiltrate into the tumor, and have enough anti-cancer cell activity. More importantly is the release of a checkpoint inhibition. Immune checkpoint inhibition. In the absence of immune checkpoint protein and their ligands, T cells are able to kill the cancer cell. So if the T cell and the tumor cell recognize the antigen and may initiate cytotoxicity. However, tumor cells are able to express ligands for these inhibitory proteins to prevent T cell cytotoxicity. In this case, PD-L1 on the tumor cell binds the PD-1 on the tumor cell and on the T cells to inhibit T cell killing of the tumor cells. The presence of a checkpoint inhibitor prevents the interaction between the checkpoint protein and the ligands, so T cell function is permitted. However, blocking the PD-L1 or PD-1 allows T cell killing of tumor cells. PD-1 CTLA-4 inhibition unlock T cells attack. There are two inhibitory mechanism. One is PD-1. One is PD-1 and PD-L1, and another one is CTLA-4 and CD80 inhibition. There are several checkpoint inhibitors on the market, The well-known one are PD-1 inhibitors such as nivolumab. Another one is pembrolizumab. Another class is PD-L1 inhibitor such as atezolizumab or durvalumab. Another class is CTLA-4 inhibitor such as ipilimumab and tremelimumab, which inhibit the CTLA-4. So, in addition of partial cell killing and inhibition of cancer cell DNA repair, one fantastic effect of hypothermia is the immunological effect. Here is the summary of the immunological effect of electro hypothermia. Hypothermia causes the tumor cell to release the heat shock proteins, which provide a dangerous signal to activate the immune system. We have proved that electrohypothermia causes the cancer cell to undergo apoptosis and increase tumor infiltrating leukocytes. Hypothermia also causes the tumors, the T cell to secrete interferon gamma and increase the PD-L1 expression of the tumor cells, making the tumor cell is more susceptible to immune response. And hypothermia also has a synergistic with immune checkpoint therapy, and we will mention later. And there is a synergistic effect with cell therapy, such as dendritic cells and gamma delta cell, T cell. I'm not going through all these mechanisms, but would like to discuss the role of electrohypothermia in tumor infiltration and dendritic cell therapy and immune checkpoint animal experiment. Other immunological effects of electrohypothermia will be addressed by my collaborator, Dr. Huang. And as early as 2003, prognosis of epithelial ovarian cancer is related to intratumoral T cells. Those patients who had no intratumoral T cells, their prognosis are dismal. So all of them die within 62 months. While those patients, their tumor have intratumoral T cells infiltration, they have much better prognosis. They even not reach the median survival after 132 months. So this demonstrates the importance of tumor T lymphocyte infiltration into tumor. So modulated electrohypothermia enhances the DC infiltration. And when tumors were inoculated into both sides of the mice, only the right side was given electrohypothermia. After 48 hours, histological examination showed dendritic cells infiltration. The DC cells were stained brown. That means electrohypothermia has destroyed the tumor cells and attracts the DC to pick up the tumor antigens. Modulated electrohypothermia enhances T cell infiltration. The tumor was taken out, and further examination showed that intense T cell infiltration of the tumor with brown stained cells. However, the number of inhibitory T regulatory cells were rare in the FOXP3 staining. Thomas in this year showed that hyperthermia facilitates NK cell infiltration into the melanoma tumor. So, hyperthermia generated tumor microenvironment that favors and permits NK cell infiltration of melanoma tumor regardless of a natural killer cell origin. Here, both primary NK cell or the NK cell line, when the NK cell is injected, so they migrate to the inoculated tumor. As shown here, and the hyperthermia cause the infiltration of the NK cell into the tumor. We also proved that hyperthermia can improve the microenvironment and favor the dendritic cell therapy. The same finding also observed in the Japanese group. They found that modulated hyperthermia enhances dendritic cell therapy through an abscopal effect in mice. Combination of hyperthermia induced local anti-tumor effects of DC therapy in vivo. We use a CT26 colon cancer cell line and the mice model. Here, the y-axis is the tumor volume and the x-axis is the days after treatment. So we noticed that hyperthermia and DC therapy combination significantly delayed local tumor growth, and as shown here, and here this curve is the moderated hyperthermia, and this one is DC alone, and this is the control. So the combined effect of hyperthermia and DC therapy greatly suppress the growth of the tumor. And combination of moderated hyperthermia induced systemic anti-tumor effect of DC therapy in vivo. And we noticed that the combined treatment show complete rejection of a secondary challenge 1 month later. So that means hyperthermia with DC generate a systemic anti-tumor effect. If we use DC alone, and the result is not quite good, but or hyperthermia alone, the best is the combination therapy. That means the dendritic cell therapy and hyperthermia generate a systemic effect, just as the Japanese group's finding. My collaborator, Dr. Huang, had done an experiment. He showed that when using anti-PD-1 together with hyperthermia, he got a very good tumor suppression effect. But if you use hyperthermia alone, the effect is not so obvious. If you use the anti-PD-1 alone, it is similar to the control. So we show that synergistic effect of PD-1 therapy and hyperthermia. So sum up, usually the microenvironment is inhibitory. That means although there are some lymphocytes there over there, but their amount may not be enough, or their quality is not so good So in such an environment, it's an immune excluded or is an immune desert. So it is insensitive to immune checkpoint therapy. But after hypothermia or hyperthermia, with the release of tumor neoantigen or damage-associated molecular patterns, so it stimulates the immune cells, so cause enough quantity of lymphocytes infiltration. So, and the microenvironment of the tumor become immune inflamed, so that in this situation, the tumor is sensitive to immune checkpoint therapy. So it is from a cold tumor, eventually after treatment with hypothermia, it become a hot tumor. So in future outlook, we usually combine hypothermia with other treatment modalities such as chemo, radiation, or target therapy. So if are there any additional benefits of adding hypothermia with these main modality together with checkpoint inhibitors? These deserve further investigation. And can we use hypothermia with double checkpoint inhibitor? Is that better? Here is some hints from the following study. In treating melanoma, if we use the checkpoint inhibitor alone, such as PD-L1 inhibitor or CTLA-4 inhibitor, they show some effects, but in combination, they show better progressive free survival or overall survival, as you see in this survival curve. The benefit of combination is better. So you may ask, will double checkpoint inhibitors further enhance therapeutic effect by adding hypothermia? So these deserve a clinical trial, but I think this trial is quite expensive. So in conclusion, this clinical case has demonstrated the possible synergistic effect of adding hypothermia to checkpoint inhibitors. Heating activates immune reaction through changing the tumor microenvironment and turns the cold tumor into a hot tumor, favoring infiltration of lymphocytes, releasing checkpoint inhibition, and enhancing lymphocyte activities. Oh, thank you very much for your attention.